So today we're going to go through a number of chest x-rays on radiopedia.org. Radiopedia is a wonderful website. It's a free open access to medical education website focusing on radiological images. It is fantastic for students, for doctors, for whoever you are. It has millions, I think, of images and case reports and learning material. Go on, you'll not be disappointed. I'm going through these chest radiographs with you because they are ones that are pertinent to finals, they're pertinent to medical school cases, and we're going to go through them. I'm not a radiologist, so it'll probably be more helpful for you because you're unlikely to be examined by a radiologist directly on radiology, if that makes sense. Moreover, there are more things you're going to come across in undergraduate medicine, but also in the first couple of years in the hospital. So let's just start. The presentation of this lady is that she's a healthy young female with sudden onset shortness of breath and right-sided pleuritic chest pain. Keys are in the history, guys. She's 25 years old, she's female. Let's have a look and see what's going on with her. So, if we start with and we always going to refer back to our original x-ray video on how to read a chest x-ray in 5 minutes with our ABCDE approach. And that means the airway, the breathing, circulation, disability and exposure. Airway, the trachea and its branches. B, breathing, the lungs and the pleural spaces. Circulation for the cardiomediastinum. D, disability, the bones, think fracture. Exposure for E is everything else, really. So let's start with that. Let's look at the airway. See the trachea going down here, it bifurcates. And that's okay. Looking into the branches, they look okay as well. Looking at breathing, the lung and the pleural spaces. So if we take this side first, this is looks normal. You can see the breast shadow, bilateral breast shadow. This is a 25-year-old female. You can see the costophrenic angles here. Looking on this side, if you try to trace around the top of that, you can't really trace the lung markings. You're tracing the lung markings here. And that goes all the way down. You can see lung markings right all the way round to the right costophrenic angle. But there is lack of that marking up here at the top. And the first thing that should make you think of is a pneumothorax, quite obviously. But don't stop there, because you will get satisfaction of search. And satisfaction of search is whenever you find the glaring abnormality, which is a right-sided pneumothorax in this patient, and you stop and you don't look at anything else. I'm going to now look at the whole way around that lung. The heart, you can trace the whole way around the heart. That's fine. You can trace the knuckle of the aorta and the aortic pulmonary window here, and that's okay as well. You're then looking for disability, bones, fracture. So what's caused this pneumothorax? Make sure there's no fractures of the lady. Make sure the rotation is okay. So it's slightly off-centered. You can see the clavicles here, the other clavicles here, and your spinous process is not quite in the middle of them. So potentially it's slightly rotated, which is why the heart is shifted towards the right a little bit. You could almost say it's a shoulder forward x-ray. An exposure, so this looks like it's adequately exposed and penetrated. So then going forward, then let's see what this looks like here. So the findings from the official radiologist, who is Ian Bickle, and that's his case number there, so go on and thank him if you've got the time, on radiopedia.org. Small right apical pneumothorax, no mediastinal shift, so that's important. We looked around the cardiac contour and there was no shift of that trachea either way that would have indicated tensioning. The left lung looks clear, the heart size is normal, and there is a right cervical rib. Indeed, whenever they point that out, there is a right cervical rib right here. So this is a pneumothorax, as it says in the report, and the treatment for which is inserting a chest drain. It is common in young slim men, so this is a lady. You have to query underlying pathology, and this would probably warrant a follow-up CT scan discussing with the respiratory team, of course, but the definitive management for this is putting in a chest drain, watching it absolve, and trying to clarify what has caused this pneumothorax. The presence of the right cervical rib is known to cause thoracic outlet syndrome, and you need to read more about that. If you don't know about it, we're not going to go into it here, but that's really about it. So there is a right side pneumothorax that needs a chest drain. Now, there's no patient information provided about this. This is a case contributed by Dr. Jeremy Jones, Radiopedia. I think it quite nicely highlights a couple of things. So if we look at the if we do what we normally do, we look at the airway first. We see the trachea. It looks like it's sort of bending a little bit there forward, but you can sort of see a slight translucency here going down. Looking across the airways, can't really see the other side. It looks under-penetrated, this x-ray in its entirety. The patient might be of a large body habitus. You could try to trace your finger around the x-ray. You can't really see that claustrophrenic angle. Certainly can't see that side. That looks like the left hemidiaphragm's quite large and overarching the cardiac contour there. You can see the lung spaces look okay, if not under-penetrated, but it's difficult to make any firm conclusions with this. The glaring abnormality is the fact that there seems to be gross cardiomegaly on this chest x-ray, and even if it was slightly rotated, and we would check by looking at the spinous process and the clavicles, but they look equidistant from that roughly. It doesn't look too rotated. This is quite a large, it must be more than greater than 50% of your cardiothoracic ratio. That looks quite a large heart, and that would be a gross cardiomegaly. Let's see if they agree. So yes, they've just said cardiomegaly here on this report. There's gross cardiomegaly with persistently raised left hemidiaphragm, and that would be in keeping with what we thought. The next patient was admitted with breathlessness and increased sputum production. This is a 65-year-old male. 65-year-old male with increased sputum production. So let's start at the beginning again. So airway, we're looking at the trachea, and it looks like it's slightly rotating off to the side there. There's calcification within the aortic arch here, the knuckle of the aorta as it folds downwards. We should trace we should then look at the lung fields, B. Looking across, there definitely seems to be very distinct borders of these ribs, and going down there looks like that's quite thick, thick lining of this side of the lung as well. The diaphragms are both quite flat, and going across there doesn't look to be any pneumothorax. Within the lung fields, however, there are strange opacifications here. That's sort of an L-shaped one here, there's one here, there's one here, and there's one here. So this is all quite abnormal looking from that. And if we look at the history, this man presented with short of breath and productive of sputum. What is the striking abnormality in this film? And I think we've already answered that. So there's bilateral geographic pleural calcification. Okay, so there's bilateral geographic, so it looks like a geographical landmark sometimes, calcification. Where are these located within the pleura? Large calcifications can be seen both in the anterior or posterior parietal pleura as well as on the diaphragmatic surfaces. So the reporter here is obviously saying that we can see plaques on the diaphragmatic surfaces as well. And you can see the pleural areas probably at the front and the back, so that's why some of them look more opaque than the posterior ones. So there are multiple geographic areas of pleural calcification, including involvement of the diaphragmatic surface, and that's here. And indeed, the author, Dr. Jones, has elucidated this for us, and you can see the plaques here that he's drawn out. Multiple geographic regions of pleural calcification, yellow dotted lines, are seen involving both the parietal pleura and the inside of the chest wall as over the diaphragmatic domes. This case demonstrates numerous calcified pleural plaques. That is probably related with asbestos exposure, and that's what pleural plaques look like. So the next case is an 80-year-old man. Oh, we'll go back. An 80-year-old man. I'm going to have a look here. So let's look. The airway looks okay. There's sort of believing the bifurcation there. Looking at the lung space and the pleura, doesn't seem to be anything too sinister. You can see the lung markings to the edges and lung markings to the edges. Here, there is, moving on to the cardiac contour, you can draw your whole way around it. There's something odd here, and that's within your lung fields / overside the heart. That looks abnormal. This side looks okay. There's a bit of chronic change here. That's all non-specific, but this looks abnormal to me. Looking at the display and exposure, there doesn't seem to be any rib fractures or anything obvious, no pneumothorax. And this is a lateral check side, which we don't really do in the UK. This is more of a US and Australian thing, but they do have a lateral view, and that shows definitely that opacification there in the left side of the chest. So this posterior anterior radiograph shows a large left mid-zone mass that can be localized to the posterior of the chest by using the silhouette sign. The left heart border remains visible, indicating that the mass cannot be anterior. Some of the left hilar vessels remain visible. There's a hilum overlay sign, indicating that the mass is not centered at the hilum. The mass therefore must be located posteriorly within the apical portion of the left lower lobe. This is confirmed on the lateral radiograph. So let's see, let's talk about a couple of things that it's mentioned there. So it says that the some of the left hilar vessels remain visible, and that's here, which means that the mass cannot be anterior, so towards the front of the chest, and that means that the heart overlies it, so the silhouette sign, the hilum overlay sign, this is not centered at the hilum, so the hilum overlies it, so you can see the vessels overlying this mass, and the heart looks like it's overlying it as well, because you can still see the contour of that heart. This means that that mass must be behind all of that, so it's in the posterior portion of the chest. And indeed, the author says that this is confirmed whenever you look at the radiograph, because you can see the heart here, and this is obviously behind. And helpfully, he's gone on to provide a axial arterial phase CT scan for this. So if we go to the very top and we work our way down, this is an arterial phase, so we'll only see the arterial phase, but we can start to see something nasty coming into shape. That should all be black because your diaphragm's here, and if we work our way up towards the head, that's the heart, lung. Oh, there's something nasty in there. That looks pretty solid and nasty. But going to our lung windows and going to the very top, this is a lot more interesting. You can see the pulmonary parenchyma, and coming down you can see the collection, the organization of tissue here that looks like a mass in that lobe, and then these are the diaphragm. So back up to this mass then. Let's see what they're finding is there's a large left lower lobe mass with narrowing of the left lower lobe main bronchus and artery. So let's see if we can find. So to find the left lower lobe main bronchus and artery, we follow the trachea down, we get to the bifurcation, that's carina, and then following this down the left hand side, you can see that that gets compressed there, the shadowing in that, and going further down, you see it's all compressed into there. And I'm afraid I'm not expert enough to look at the the lower lobe artery. So the discussion here says that lung cancer with the apical portion of the left lower lobe, that's what it is. It's a large cancer with apical portion of the left lower lobe. Nice example of how the silhouette sign and hilum overlay sign on that initial chest x-ray can help localize a chest lesion on a frontal projection alone. Cytology showed that bronchial washings showed malignant cells originating from a non-small cell carcinoma, and we talked about that in one of our respiratory review videos, best seen in the bronchial brushings from the left lower lobe, where the cytomorphology is suggestive of adenocarcinoma. The next case is of a 71-year-old female, contributed by Dr. Bickel again. Patient presents with chest pain and shortness of breath, 71-year-old female. So, see, this is actually it's a PA erect X-ray, and we'll start at the beginning. So airway, you can vaguely see the bronchi going in either side. It's a little clearer on the left than on the right. You can see whenever we go to B, we look at the lung field, so we look all the way round. First of all, it doesn't seem to be any pneumothorax or sort of organising collections down here. You can still see translucency here. And let's move to C. So we can see the cardiac outlet. This looks a bit patchy here, going the whole way around. This looks patchy. This looks very abnormal here, and looks to be connected to the ascending and descending aorta. So that is a worrying sign in its entirety. Just to be complete, we're looking at the exposure. So it looks adequately penetrated, and it looks minimally rotated. You can see the spinous processes are roughly in the middle of your your clavicles. So we're mostly concerned with this picture in the middle here and what on earth that represents, because it's connected to the descending aorta. Markedly dilated thoracic aorta involving the arch and descending aorta. So the arch is here and the descending aorta goes down. The heart size is the upper limit of normal and the lungs are clear. So this is obviously quite a worrying feature. This is unfolding of the aorta. A thoracic aortic aneurysm is less common than an abdominal aortic aneurysm, we know that. Ectasia, which means unfolding of the aorta, is often identified incidentally in the elderly population and a more common cause of thoracic aortic dilatation. Moving on then, our next patient is complaining of dyspnea. She's 19, lady. So let's have a think about what's going on in this chest x-ray. So the first thing we look at is the airspace. So we look at the airway. So you see it's bifurcating nicely there. And to go around the pulmonary markings look all okay. Around the sides, this looks abnormal, right? Mid and lower zone opacifications there. It looks hazy, certainly. Nothing really there. You can see the cardiac contours okay. And just on a quick glance, there doesn't seem to be any fractures or anything like that. So no pneumothorax, no fractures, and there's a hazy portion of the right mid and lower zones, and there's a central line in place. It looks like it's just going into the superior vena cava, and that looks like it's an artifact portion of this. So this looks abnormal here in this zone. Let's see what it says. The tip of the central venous catheter is projecting over the superior vena cava. There's minor hazy airspace opacification in the right, mid and lower zones. The pleural space are clear. Cardiomediastinal contours are normal. So this all looks normal to the professional radiologist. Going forward then, okay. So we'll look at the axial lung window. This is probably the most useful for us. We'll go upward towards the trachea, so trachea coming down into the lungs. There's certainly a lot of opacities in both lung fields, particularly on the left hand side here, and going across. What could that be? That's all in there. Let's see, coronal lung window. Let's look at this a bit better. So this is the let me see the front. So let's go in from the front. Looking forward, that's the heart. You can see the tip of the CVC, the central venous catheter. You can see all this opacity here. But you can see the clear bifurcation of the trachea into the right and left main bronchus and its divisions all the way down here. You can see the fissure, the division of the lobe quite clearly there, because of the extra markings there. But this all looks quite abnormal. So there were no contrast scans available due to renal function, but there's diffuse patchy ground glass opacity within both lungs, predominantly in the upper lobes and apical lower lobes, with relative sparing of the bases. Compared with the prior examination that they have, obviously from a month ago, this is improved within the right lung, but it's more confluent within the left lung, with infiltrates seen both centrally and peripherally. No interlobular septal thickening or nodules. The airways are normal and pleural spaces are clear. There's no pericardial effusion, no thoracic lymphadenopathy, no suspicious osseous lesions. Right, very good. So the conclusion is there's diffuse alveolar infiltrates, which we got, predominantly within the upper lobes and apical lower lobes. They appear more confluent on the left and improved on the right compared with 1 month ago. Given the patient's history of Goodpasture syndrome, okay, so this changes what we think. Goodpasture syndrome appearances are in keeping with pulmonary hemorrhage. So this now makes an awful lot of sense. And it's important to realise that history is everything. If we'd had thought this patient's got Goodpasture syndrome, would it have changed what our immediate sort of thought was on this? And the answer is, if you know what Goodpasture syndrome is, it probably does. Because as you will know, Goodpasture syndrome is a rare autoimmune disease in which antibodies attack the basement membranes in the lungs and the kidneys, leading to bleeding from the lungs and the kidney. This actually causes kidney failure as well, and bleeding in the lungs. It's thought to attack the alpha-3 subunit of type 4 collagen. which has therefore been referred to as good pasture's antigen. So this is an interesting insight into what pulmonary hemorrhage would look like on a CT scan, but also how innocuous it actually looked on a chest radiograph. It was very non-specific and very hard to see, so it shows what shows up on a CT scan. So the final words for this case are that Goodpasture syndrome is due to anti-GBM autoantibodies and causes pulmonary hemorrhage and glomerulonephritis. Hope you enjoyed these cases. There's more of them on their way. Once again, a big shout out to Radiopedia, which is free open access education in radiology, in radiography, lots and lots of cases on it. You should become a Radiopedia supporter today. There's exclusive perks, and you can contribute your own images to them if you support them. They're a great resource. That last case was courtesy of Dr. Jeffrey Lai. There is a good way of sort of looking up their individual images with that case ID there, RID 38307. So if you want to see any of the cases, all of the information is always at the bottom of the screen whenever I'm doing these videos, in order to give them a good shout out. This is all free open access medical education, guys, so please do support them. Do sign up and go and have a look at their website. If you like more of these videos, let me know. Comment in the description field below. Don't forget to subscribe to the channel, and I'll see you very soon.